Completed 2 minutes. Now started 10 minutes time.
Okay. Hello, I'm Dr. Harita, one of the Part 3 candidates. I read my case scenario and I'm ready for structured case-based discussion.
Okay, so after going through this case, what further investigation you would like to do in this case?
Um, uh, I understand from the case scenario that she is 29-year-old, primary gravida, and she is at 34 weeks. Her and her BMI is 34, and her sugars were high, so she was detected to be having diabetes. And right now, the scan shows that baby is macrosomic onto the higher side. I would like to know about whether she was started on any kind of treatment, whether she was offered metformin or insulin, and whether she is regular with her medications, and how her sugars have been, and any present complaints right now she has.
No, she is the test which is actually done for detecting diabetes is negative, normal. GTT is normal, oral
Okay.
glucose tolerance test.
Okay, then at this point she's already 30. She's already 32 weeks, and symphysis fungal height is more than what we expect. So I would like to test her for blood sugars. That would be either with HbA1c or fasting and postprandial blood sugars as well. Because first thing is I would like to rule out whether it is related to high blood sugars. If her blood sugars are high, then whether there as a previous scan was not showing anomalies, chances of anomalies are also less. This could also be due to idiopathic condition responsible for polyhydramnios. But here the weight of the baby is also high, so I would be thinking more of any diabetes mellitus, gestational diabetes mellitus.
Okay. So now after the investigations, how what will be your approach?
If her blood
How
sugars happen to be
what will be
high,
the plan? What will be the plan
yeah.
next?
Yes, yes. If her blood sugars are high, it implies that those have not been under control. So, along with the diet and exercise, I would also start her on insulin. This will be a multidisciplinary team approach involving diabetologist as well. But
No,
because her
so her sugars are normal.
Okay. As our sugars are normal, we would like to continue to see how the baby is doing, and maybe after 2 weeks we would like to ask for a repeat scan. This time along with Doppler as well to look for any compromise with the blood supply as well, and the safety netting to for the woman to have an eye over about baby's movements and to report to the hospital immediately if she notices any kind of vaginal loss as well. And if she develops any kind of difficulty in breathing, any shortness of breath due to polyhydramnios, that also we would be warning her.
Okay. Um, Now at 38 weeks of gestation, the patients come in labor. What will be your further management?
I would like to see whether I would like to have know her blood pressure and send urine for protein as well, and to look for the presentation and whether she is in labor and the frequency of contractions and the vaginal dilatation as well. If there is a provision of ultrasound, I would like to do an ultrasound to have an estimated fetal weight, and if the weight is anything above. Sorry, if the weight is anything above 4 kg or like depending on her height, I may have to assess whether vaginal delivery can be allowed, or we have to think of even cesarean if the weight of the baby is onto the higher side, after explaining her the risks associated with it as well.
You decided to go for vaginal delivery. What next?
Okay, we would like to because of polyhydramnios, it is going to be in a consultant-led unit with continuous fetal monitoring, and reassessing her every 4 hours as per the. In the first stage, we are going to reassess her every 4 hours. We would be just screening her once again if there could be any sugars as well. And then, depending on her contractions and the vaginal dilatation, we may have to repeat assessment fourth hourly as well. And for pain relief, we can offer her epidural analgesia as well after discussing with anesthesia colleague and counseling her. And in the second and we would also ask for an anesthetic review, as there could be a need for difficult prolonged labor, or even there could be a chance of shoulder dystocia as well. I'll also inform my consultant on call regarding this patient, and then we'll be regarding this patient. And then depending on the, like, once she enters into second stage, we'll alert our staff, and we'll also tell them that if there is a need, if we give them continuous monitoring will be happening, and we may have to secure an IV cannula in case there is heavy bleeding after delivery as well. And then we'll also keep everything ready for postpartum hemorrhage, like oxytocin injections, even carboprost, tranexamic acid as well, so that if there is a need, so it can be given immediately. And during delivery, I would alert my team that if we, at any time, if there is any shoulder dystocia happening, then once we announce shoulder dystocia, they'll all be ready with the maneuvers as well. I'll tell them again, retell them like how to keep the limbs when there is announcement of shoulder dystocia. And the first maneuver we are going to do would be like McRoberts maneuver. And we'll also involve our like pediatric team as well, who are experienced in managing the babies, that there could be a potential chance of shoulder dystocia as well. And after delivery, if she
So
has
at full dilatation, there is shoulder dystocia. How you are going to manage her now?
I'll call for help. I'll reassess and see. I'll call for help. I will evaluate episiotomy. If bladder was not drained, I will immediately drain the bladder. And then I'll first announce shoulder dystocia, so that the one who are assisting me knows that there is shoulder dystocia, and immediately legs are flexed, and abduct. I mean, legs are flexed over to abdomen, as well as open up little. I mean, bit, so that McRoberts position is taken. And then gentle traction I would apply and see. Other than if that's not working, then we would go for even suprapubic pressure as well. If that's also not working, then we may have to think of corkscrews or reverse corkscrews maneuver. If these are not working, then I may have to counsel and press the emergency buzzer, and may have to take her up. Like, all fours will also be tried. If that's also not working, then I may have to think of Zavanelli's method, the baby inside, and then shifting the baby immediately for cesarean. Meanwhile, we'll inform the midwife coordinator to arrange theater, and one of us will be noting down the shoulder dystocia protocol as well, to know the different timings, at what time what maneuver was undertaken as well.
Okay.
And
Anything
anesthesia.
else? Anything else you wanted to add to any of the point, any of the question?
At the end, if shoulder dystocia has happened, then I would like to generate, incident report, and debrief the woman after, whenever things are favorable, as soon as it's practically possible.
Okay.
Thanks for your time.
Last 40 seconds.
Mm.
Anything else you wanted to add? Shall we ask the feedback from the others?
Yes, ma'am, we'll ask.
Okay. Anybody wanted to give a feedback to her? Good attempt. Needs improvement. Okay. Anybody wanted to give feedback to her?
Yes, ma'am. When there was the approach to the patient, then we should have started like how will you counsel the patient and take the history from her, and also then outline the management with her, what
Yes.
risks she has, and what are
Yeah.
the maternal risk and the fetal risk. Explain it to the patient.
Diagnosis of the condition and its implication. That is very important. What we had diagnosed, explain that to the patient in a layman language, what is LGA. Here, the sugars are normal. Even the subsequent sugars are, we are suspecting that they are, means we are expecting that they are normal. So, implication of that condition on the mother and the baby. The way she said, shoulder dystocia. So, you need to explain. That is very correct asking. Approach is, that is what the approach is there. Yes. Anything else?
Ma'am, if
And
we
again,
cannot,
when she was in labor, then we should have been a consultant-led care with group and save done, and
Yeah,
also
group and
noting
she missed.
CBC, yes, CBC, IV access,
Hmm.
as well as counsel the patient about the need for interventions and high risk of shoulder dystocia.
Hmm.
And accordingly, we have to take the patient along.
Yeah, so it missed out on few important points, and that's the reason a good attempt, Harshit. But we need to improve on that important points. What points you are missing out? That should not be into the answer key. If those are the points which we are missing out from the answer key, then it is difficult here. Okay. In spite of a good attempt, we might not be able to pass the exam. Rightly see, and here at 26 weeks, she had an oral glucose tolerance test, which was normal. So identifying the information, whatever information has been given, interpreting it correctly is very important. Very, very important. Huh? So these are the points which you need to mention in your history, means whatever pen and paper you are having. So here you can just mention a 29-year primary, 34 weeks. Okay. Booked at 11 weeks means you know that 11 weeks unplanned BMI. She is having high BMI. 34 is her BMI. So one risk factor is her BMI. Blood group is positive. Rest of this combined screen is negative, and the pregnancy is low risk. OGTT was done, which was normal at 26 weeks, and 20 weeks she had a detailed scan, which was also normal. And she was under a midwifery layered care unit till last week when her fundal height was very, means it was 38 weeks, 38 centimeter at 34 weeks of gestation. So these are the points what you have to remember in your mind. And when single task is there, it is very easy to remember. And that's the reason whenever you are practicing 14 tasks at a stretch, it is very difficult to keep information into your mind, and that time your mind get clogged, so you may not interpret that information properly. So from now onwards only you need to interpret whatever information has been given to you appropriately. Cephalic presentation, placenta fundal. So this is more than 95th or 95th percentile. That means it's a large for gestational age baby or LGA baby with polyhydramnios. Now 10 minutes where we are going to ask. So my first question is, what investigation you would like to order for her and why? Why is very important. So S bar, I had mentioned that situation is large for gestational age prime baby with in a case of primary gravida 34 weeks. High risk factor here is only 34. BMI is 34. Rest all information is negative, including her sugars. Anomaly is also negative. Anomaly is also negative. So what in further evaluation? So here, although I know that her OGTT was normal at 26 weeks of gestation, still I would like to check her blood sugar, especially fasting and PGBS or post prandial. If they are abnormal, then HbA1c. Full blood count also had mentioned here because she is a case of polyhydramnios, which is at risk of PPH. So her hemoglobin should be optimized, and that's the reason full blood count. If not, then the iron supplementation can be started on this patient. Serial growth scan with Doppler flow subsequently. So not only the next ultrasonography. From 34 weeks onward, she will be on a serial growth scan. The next scan will be after 2 weeks and after that they will again decide when the next scan will be needed. So serial growth scan is an appropriate word. Please use that word only with Doppler flows. For interventions as large for gestational age babies are at risk of complications like protracted labor, perineal trauma, perineal tear, PPH, and shoulder dystocia. That SD is shoulder dystocia. Since polyhydramnios, she is at risk of cord prolapse, PPROM, preterm, and even abruption. Hmm? So, looking at her, she is a high risk case. So, what will be your approach, or what will be the plan for the next time? Now, the patient is from low risk. The patient has been converted into high risk pregnancy. Identify it and mention from low risk pregnancy. The patient now comes into a high risk category, so patient needs to be booked under consultant led care unit. A serial growth scan will be offered to these patients, including Doppler. Explain to mother what is mean by LGA or a large for gestational age baby, and what are the implication of this baby, this LGA. So implication will be maternal and fetal. For maternal, we may have to induce her early. The patient may have PPROM, preterm labor, protracted or prolonged labor, cord prolapse, abruption, difficult traumatic labor, shoulder dystocia for the baby. Baby might have some concerns or NICU admission. So for the baby, it is shoulder dystocia and admission to NICU and evaluation after the delivery, because the polyhydramnios many a times it will be idiopathy. Although the congenital abnormalities are not been seen on anomaly scan, but we need to still watch for the any abnormalities. And serial follow-up. So serial follow-up with the consultant-led care unit, DFKC, very important. And patient will be explained that she needs to count a daily fetal kick count. If there is any concerns with the fetal movement, report with sharing 24-hour contact details, when to report, where to report. And again, so this is an antenatal plan. So but if you have identified it as a LGA, so at what gestation you would like to end this pregnancy? So according to guideline, at 38 weeks, generally we will discuss the option of induction of labor or cesarean section if it is diabetes with LGA, or if without diabetes the 4.5 kg is an birth weight. Okay, so without diabetes it is 4.5, with diabetes it is 4 kg. So it depends upon the assessment at 38 weeks, but we need to discuss mode of delivery with the patients by the consultant. So this is what the we plan for this patient in the upcoming days. Now she present in labor at 38 weeks of gestation. So here, dear, you had missed out. Okay, consultant-led care unit you mentioned in this question. Harshida, if you had missed out on previous question, this point in the previous question, you will not be marked in this question. If you are mentioning that consultant-led care unit, the point needs to be mentioned in that particular answer, then only it carries a meaning. Otherwise, it doesn't carry a meaning. Explain when you are going to involve, not at the time of labor, you are going to involve the patient consultant from the moment the patient uh, has been recategorized into a high risk pregnancy. Yes. So
Okay.
the first thing is admission test and continuous fetal heart rate monitoring. You mentioned this. No, you had missed out on this fetal heart rate monitoring. Totally forgotten. Totally forgotten. You, because see, we should go systematically. Okay,
No,
we
I
should go.
told, ma'am.
You mentioned
Yeah,
fetal
yeah.
heart rate.
Continuous monitoring, I told.
You mentioned, okay, so I missed out on that one word. Then assess stage of labor. At what stage of labor patient's vitals needs to be examined, abdominal examination needs to be done, and per speculum for vaginal examination to assess the stage of labor. uh, if in active stage of labor, then here we are going to offer this patient one-to-one care. IV line, group save. You missed out on group save, that you remember. You mentioned only IV line, and the next sentence was oxytocin, but you didn't mention about group and save. So because these patients are at risk of PPH, you will be uh, Going for IV line, group save, and even full blood count also. Here also you would like to know what is her hemoglobin, current hemoglobin. Assess presenting part if needed, arrange bedside ultrasonography. Since the patient is having polyhydramnios, controlled ARM is very important to prevent cord prolapse. Patient's labor progress needs to be charted on a partogram. Because these patients are at risk of prolonged labor and shoulder dystocia, and we can discuss adequate analgesia with the patients also. So this is a labor plan. So far as anything you wanted to add to this, any deviation from normal, patient needs to be informed to the consultant, patient needs to be informed. Consultant, anesthetist, and theater team will be alerted in this case, because likelihood chances the patient may require any intervention. So they will be alerted. She progressed to full dilatation, but there is a delay in crowning of the head. After the initial delay, the patient delivers shoulder stuck. So you have diagnosed as a shoulder dystocia. Yes, you rightly mentioned that this is an emergency. Call for help. Whom you are going to call, dear, here and there only you please name those patients, name those people. Because if you will not name those people at that time, it will be missed out by you. So then and there only involve the people who are in you are going to call. Press the buzzer. Senior midwife, along with midwife assistants, labor ward coordinator, neonatologist, anesthetist, consultant, or ST567 needs to be informed. Though the senior most personnel needs to be informed. Ask someone to note down on time, which you had mentioned, and even documentation. Introduce and communicate with the patient, very important. Here we have to keep this patient in loop, because you are going to get assessed on communication with patient and family domain. So you have to introduce to the patient, communicate with the patient, and uh, explain her that we are experiencing this shoulder dystocia. So maternal pushing should be discouraged. Avoid any fundal pressure. Patient needs to be lie flat on a table. Taking patient and the perineum, the patient's the lithotomy position, either it in a lithotomy position or dorsal position, and the patient will be towards the edge of the table. Edge of the table, no pillow will be given to the patient. Very important points, very important points. Here at this point or further, we need to assess the need for episiotomy, because we are going to require certain maneuvers, although it's not a bony obstructions. Very important to remember a helper mnemonic when it comes to shoulder dystocia. Call for help will be the first point which we had done. Now the next will be elevation or leg elevation. So that is macrobuts uh, maneuver. Macrobuts maneuver. Evaluate for episiotomy and legs. Third will be leg. That is macrobuts maneuver. Hyperflexion. What is this maneuver? You have to explain, dear. You will be getting marked unless and until you will not explain the maneuvers. You will, just by mentioning the name, you will not get it. So hyperflexion and abduction of legs, which straightens the lumbosacral angle, increases AP diameter, rotate pelvis cephalate. The success rate is 90%. Low rate of complication, and is one of the least invasive maneuver, and therefore it is the maneuver which needs to be applied first. So macrobot will be always first line. Second will be pressure, that is suprapubic pressure, which needs to be in a axial direction. Okay, so that the bisacromial diameter will be reduced, and the anterior fetal shoulder rotates towards the wider oblique pelvic diameter rather than into the AP diameter. It will be into the wider pelvic diameter. Rotational maneuver, if at all this fails, in most of the cases, 90% of the cases, the baby will be delivered with the first two maneuvers. But if at all it will fail, then there will be rotational maneuvers. This needs to be entered through the posterior vaginal halo, and the rotational maneuvers needs to be done here. Internal rotation, delivery of the posterior arm by rotation into the oblique diameter, or whenever possible by full 180-degree. So this, the third line will be rotational maneuvers, and if at all here, or if you are going to, if here you are not going to deliver the baby, here you are going to inform the consultant immediately, and we may have to take this patient to the theater. Meanwhile, rollover position or all four position can be given to the patient to try the last maneuver. And if at all by this maneuvers the patient will not able to deliver or the shoulder dystocia will not get resolved, then we may have to consider the next line of maneuvers will be that is Zavelinis. Okay, and it will be difficult maneuver. Patient, this needs to be done by the consultant, so the consultant will be available for this procedure. You cannot do this procedure on your own. Remember this way. The way you mentioned that I will go for the next, I will go for the next. No, your limit will be till roll over or all four position. Once the destructive maneuver or the Zivenalis maneuver will be required, you are not going to touch the this patient. Max to max, you may reattempt again. You may reattempt from first, second, third maneuver, but this maneuvers, the Zivenalis maneuver or any destructive maneuvers will be done or decided by the consultant. Your consultant need to be involved at this point. Then call senior consultant and may need third line of management, that is destructive or Zavenalis maneuver. Now explain maneuvers on mannequin and show correct method to do it. If there is any mannequin, you can explain it. Allow, this is basically in the teaching thing. Okay. Uh, Documentation is very important. Incident reporting is very important, and debriefing to the patient. Neonatologist assessment by the baby. Complete delivery and placenta. Explore genital tract for any trauma. If there are any trauma, repair of the trauma. Clinical governance part is assessment, DVT, debriefing, documentation, and datics. These are the points which you are going to say in clinical incident complete that means clinical governance points. Active management of third stage of labor is another important point. Once the patient will be stable, we can encourage breastfeeding, arrange debriefing, share patient information leaflet, and there are birth trauma support groups. We can share the discussion, we can share the details of those support group also. So these are very means few of the very important points you had missed out, dear. So see to it that you will not miss out on those. Able to interpret ultrasound findings, request for additional investigation to rule out GDM and fetal abnormalities, investigate in labor, anticipation complication, that is full blood count and IV line, very important. Lies with imaging for serial ultrasonography, exclusion of structural causes since polyhydramnios, communicate with colleague in primary care and other specialties, that is obstetric anesthetist and neonatologist. Understand the risk management and clinical governance process, awareness of the complication of cord prolapse, shoulder dystocia, and anticipation, and what are the measures you are going to take, that is patient safety. Active management of second stage of labor, very important. This is again patient safety point. Being prepared for the management of postpartum hemorrhage if at all it happens. So IV line, group, and active management, these are the important points which should not have been missed out. Knowledge of antenatal care of a woman with polyhydramnios and macrosomia, including gestational diabetes, has an understanding of the management of shoulder dystocia. Knowledge in the recent guidelines on shoulder dystocia, literature, macrosomia, polyhydramnios, RCOG Green Top Guideline, current literature. Communication with patient and family. Here you are going to introduce yourself, discuss the investigation with the patient with her follow-up antenatal care plan, discuss the topic with the patient sensitively, appropriately, encouraging questions. Communication of the means communicating with the patient the rest of the management plan, especially consultant led care booking and labor plan, including complications. What are the complications can be anticipated in her, and how you are going to minimize those complications. Involve the neonatologist regarding the post delivery care of the newborn in view of polyhydramnios, because there might be any congenital abnormality might be missed out, so that assessment by the neonatologist is very important. That also needs to be communicated with the patient. Okay, so you need to improve a good attempt. I will not say means you were quite structured, it was not monotonous also, you were to the point, but the important point you need to know, and when you are going to, which points you are going to say in which question, that is also very important here.